So, good afternoon to all of you viewers. We are going to talk to you about unmasking the advances in melasma management. So, this is going to be a talk where we're going to talk about how we've progressed from what we are going on now and what could be there as we go on in the future. And some of those treatments are actually based on what is currently thought are the pathogenetic mechanisms of melasma. So melasma, as you know, is a common disorder. It's symmetrical acquired hypermelanosis. We know what how it presents: dark brown or light brown macules over the face, which are located in particular areas. We know those areas. They usually mostly affect women, but yes, they can affect men as well. Very common in our kind of skin. In fact, skin type 3 going on to skin type 5 are the most common skin types which are affected by melasma. It's yes difficult to treat. It affects the quality of life significantly, and of course, the chronicity is a problem, and treatment is something which has to be going on and on and on. So this is one problem. I'm going to just sort of illustrate one patient. You see, it's more of a self-confidence issue. And sometimes, for example, this particular patient, you see the before and after, the treatment effect, I would say, is sort of modest. It's there. I mean, it's improved, but it's not really improved that much. But this patient is really much better off. This patient was on combination treatment with topicals, with chemical peels, we just sort of improve the general skin color and texture as well. And even though the melasma itself is reduced to a modest degree, but she is very happy. So that is very, very important that it affects the patient's psyche. And even if you're able to give a bit of improvement and a bit of improvement in texture, these patients are much happier. So clinically, as I said, yes, these present in three different ways. We call it the centrofacial melasma. Malar melasma, of course, is much more common in southern India. Otherwise, overall, worldwide, the centrofacial melasma is said to be more common. The mandibular melasma, of course, I'll come to that. It could be possibly a manifestation of poikiloderma of Sivat and rather than melasma. So these are protracted resistance treatment, and of course it keeps recurring after discontinuation, and this happens basically because of changes in sun exposure, changes in seasons, etc. So this, of course, is predominantly centrofacial melasma, as you can see here. The central part of the face is involved. This is malar melasma, typical. The malar areas are involved. The malar melasma. And of course, mandibular melasma. This is a mandibular melasma. Now, this is most probably more linked to poikiloderma of Sivat rather than melasma. So we have now this bit of knowledge that this is probably to be treated more like Sivat's poikiloderma. So the predisposing factors, of course, we know sun exposure, familial. Yes, familial predisposition is important. Pregnancy is important. Hormonal influences, of course, are important. We're going to talk about some of the hormonal influence and how we sort of, uh, you know, uh, going forward, there are plans to tackle this particular aspect of melasma. Now, we used to think of melasma as being compartmentalized into epidermal, dermal, and mixed. But now we know that probably all melasma in our skin is probably mixed in melasma. You have a dermal component and an epidermal component in almost all cases of melasma. For example, let's say this see this patient. Now here this is a little grayish melasma. This is more dermal and this is more brownish, more epidermal. So in the same patient, you can have a mixed component, and that's why we say that melasma in our kind of skin is probably mixed rather than compartmentalized. Now, of course, the pathogenesis is a very complex interaction. There are hormonal influences, genetic factors, the ultraviolet exposure, which causes changes to epidermal melanocytes. It causes changes to keratinocytes, and of course, they are associated with dermal fibroblast changes, and of course, very importantly, vascular endothelial cells, which are responsible for some of the effects which we see on the skin. We also now know, for example, if you have this upper lip melasma, it's probably there could be a relationship with oral contraceptive use. So various types of melasma, various morphologies, and we could probably identify some etiopathogenetic mechanism based on what we see on the patient's face. And in some patients, I showed you mandibular, and I'm showing this upper lip melasma. Of course, this is something which you all know very well. Melanogenesis affected by age, ethnicity, ultraviolet rays, and of course, drugs, photosensitive drugs, certain antipsychotic drugs, etc. But what I really would like to draw your attention to is the fact that we have this MITF, microphthalmia associated transcription factor. Now, this is what is acted upon by a lot of these factors which actually induce melasma, and these stimulate tyrosinase and tyrosinase like protein 1 and 2, and this actually drives melanogenesis, which is basically the formation of the U and the pheomelanin, which of course is decided by the proportion of activation of PYRP1 and PYRP2, which leads to a difference between whether what kind of pigment we are likely to get. So melanogenesis is a complex process, and it is controlled by various factors, including cytokines, including hormones, including growth factors, including the Wnt pathways, stem cell factors, CK, a lot of factors. But this MITF is one thing which probably unites all these factors and stimulates tyrosinase through TYRP1 and 2, which drives melanogenesis. A lot of future actions on melasma management could be related to somehow getting a hold of MITF. So this is a nice little cartoon which really talks about how melasma forms. Now you see when ultraviolet light happens, you get the activation of keratinocytes. It's like the customer's identified need, and this tells the keratinocyte tells the melanocyte, now look, now you knew a factory needs to start working, and then of course the machine starts to work. Now, in hyperpigmentation, which happens in melasma, what really happens is the keratinocytes get overstocked with pigment, and this happens basically because of increased shipping of melanin through the melanosomes from the melanocytes to the keratinocytes, which probably, of course, in which inflammation is an important factor. Also, this melanin not only goes up, it also comes down to the dermis. We call this the misplaced shipment. So therefore, you have an epidermal as well as a dermal component once the activation of the melanocytes and the increasing, transfer of melanin occurs from the melanocytes to the keratinocytes. So this is basically, a simplified diagram which tells you how this process actually leads to an epidermal and dermal component both in melasma. So the treatment goal definitely is the improvement of existing lesions, prevention of recurrence, etc. Now these are the current therapeutic options. I'm just going to sort of touch upon some of these. For example, we have the depigmenting agents, a lot of which act through tyrosinase, hydroquinone, of course, azelaic acid, vitamin C, kojic acid, 4-butyl resorcinol, also called rucinol. Then, of course, we have the retinoids. The retinoids we know act through various mechanisms, but a very important part of the functioning of topical retinoids is that they facilitate the transepidermal penetration of other topical therapies, and that is one of the methods. Of course, it has got various other mechanics by which it acts on melasma, but this is, in my mind, a very important mechanism by which it works. Corticosteroids, definitely, it's a non-selective suppressor of melanogenesis. Photoprotection, very important. In addition to protecting the light from going in, that has a corollary effect because ultraviolet light generates reactive oxygen species. We talked about that a little later. So this, of course, prevents the generation of ROS. Topical tranexamic acid as well as intradermal tranexamic acid, definitely. The topical probably a little bit better than intradermal, or maybe both very similar, but definitely the systemic works much better than that. We're going to talk about the systemic in a bit. First, the very important agent that we use are triple combination. The triple combination definitely is probably, we call it the raison d'etre of management of melasma. And how I do it is I treat them with initial about 2 to 3 months of every night treatment, and thereafter going on to weekend therapy. Now, of course, if you're having a very severe melasma, sometimes the weekend therapy may lead to a bit of a relapse. So sometimes even post about 8 weeks, you may need to go on for alternate day therapy rather than weekend therapy. But most patients, after about 8 weeks or so, a weekend therapy works to keep their melasma under control and keep adverse effects in check. Of course, there are other combinations available with glycolic acid, with kojic acid, with or without hydroquinone, various combinations which are available in the market. So these are your standard predominant current topicals available. Now, what about the systemics currently available? Of course, tranexamic acid is probably the most important systemic that we have at the moment. What is important is that we always talk about a DVT risk. Now, what we need to understand is the dosage that we use in dermatology, the DVT risk is really not significant. It doesn't really form an important, issue as far as melasma management patients are concerned. But another way tranexamic acid works is through the mast cells. Now we'll come to that a little later. How the mast cells are an important cog in the wheel as far as melasma is concerned. And drugs such as tranexamic acid, even topical zinc sulfate, to an extent, even Q-switch NDI lasers work through this particular mechanism, and that is the mast cell. Now, these are also again an emerging pathogenetic mechanism of melasma, and handling mast cells with these agents. These mast cells seem to be a little different. They don't has antihistamines don't seem to work on them, but drugs such as tranexamic acid, I mentioned zinc sulfate, seem to work on these mast cells. Of course, the other drugs, of course, polypodium glucotones orally, really the benefit have not been found to be very, very significant. Oral glutathione, yes, oral proanthocyanidine, peroxy antioxidants, carotenoids, melatonin, to an extent, not really as effective as tranexamic acid. So in systemic, really the sumo as on today is definitely tranexamic acid. This is a drug which acts very, very well, especially in patients who are not responding to your standard topical line of therapy. So having gone through the topical and the current systemics, of course, we'll come to chemical peels and lasers quite definitely. Now, what we need to understand is chemical peels are controversial as best in melasma. They can be used in combination, but chemical peels, especially glycolic acid, in all published studies, even in clinical practice, they can be associated with post-inflammatory hyperpigmentation. So therefore, it's always best to combine it with topicals and never to use this alone. In fact, I use peels very, very infrequently in melasma. My book, chemical peels aren't my go-to agents in melasma. It's topical and topical and topical. Salicylic acid again doesn't work too well. TCA again, risk of PIP. There are other peels. In fact, it's better to use some of these milder peeling agents such as arginine, lactic acid. I'll show you some of those images. Even phytic acid, they seem to work quite well. The salimandelic peel seems to be working quite well, and the reason why this works well is that the mandelic acid has got a higher molecular weight, and this somehow beds much better into the skin and seems to work better because of its higher molecular weight. So the salimandelic is probably a reasonably good idea when you're using chemical peels and melasma. Coming to laser and light-based therapy, again, use conservative settings if you're going to use them at all. Again, the issue is the development of post-inflammatory pigmentation. Here, the use of tranexamic acid with lasers or and light-based therapy is a good idea. So IPL, fractional IPLs, definitely QC10 laser in tone mode, so really low fluence, 0.8 to 1 joule per centimeter square tops is what I use. This of course works on melanophages, but it also works on vessels. It also works on the mast cells. So that's why I mentioned the Q-switch laser has two, three different mechanisms of action. It is not only the photoacoustic effect on the melanophages. It has some other effects, and that is why the low fluence mode actually works. Of course, the pulse dye laser again with the triple combination. So all these agents best to use it with either tranexamic acid or a topical agent. Fractional laser is not a great idea in our kind of skin. Other lasers, for example, they've tried things such as copper bromide lasers, etc. So, in a nutshell, lasers, one needs to be careful, and always lasers and peels in combination with other treatment modalities. And if your topicals aren't working, and if you have even tried tranexamic acid, it hasn't given you the results. So, probably those are the situations you can use these. But whenever using a procedure, it's good to use tranexamic acid to prevent that post inflammatory pigmentation. So this is again very mild peeling agent. These are these lactic acid peels, and they work quite well, of course, in association with medical therapy. So befores and afters. Now this is a patient who looked like having dermal melasma. Now this is just medical therapy with just an arginine, few settings of arginine peel, which really does well. So medical therapy does well, and milder peeling agents probably rather than stronger peeling agents. Of course, the people have used fractional lasers even in our type of skin, but this is something which I sort of don't really do very much. So fractional lasers, I think, in our kind of setting is not a great idea. Of course, I'm going to talk to you about why we need some of these newer agents. Now, let's say talking about hydroquinone. Hydroquinone, of course, a very highly studied drug. It's a tyrosinase inhibitor, most well-studied agent. But the issue is that hydroquinone on long-term use sometimes can be a bit of a problem. This confetti like depigmentation can happen, and of course, soft renosis, something which we do see in our kind of skin. We do see these cases in our kind of skin. So therefore, there is a need for newer agents. There is a need for agents which not only target melanin, they target some of the other mechanics of melasma, such as I mentioned, the mast cells, such as the hormonal mechanisms, such as the vascular mechanisms, etc. Of course, we are targeting the vascular aspect with tranexamic acid even now, but some other agents which can probably be used. So, of course, we need to target the hyperactivity of the melanocytes. In addition to, of course, melanin production, we need to target inflammation, free radical formation. We need to target the melanoma transfer, the vascular aspect, mast cells, hormones, and of course, the barrier function. So I'm going to talk about how we can probably target each and every one of these mechanisms. So coming to hyperactive melanocytes, linoleic acid, ascorbic acid, these are two agents which reduce the hyperactivity of melanocytes. So therefore, this reduces, of course, the UVB-induced post-inflammatory uh, exacerbation of pigmentation of melasma. So that is one agent how linoleic acid works. Ascorbic acid, we know it's a copper chelator. It decreases tyrosinase activity, but also reduces the activity of the hyperactivity of the melanocytes. Very importantly, ascorbic acid reduces dermal damage, promotes collagen synthesis, and of course is an antioxidant and a photoprotective. So ascorbic acid has multiple roles, roles which are best in conjunction with other agents. But ascorbic acid has a reasonably good role. Then, of course, N-acetyl acetylphosphatidylphenol. This is an agent which is less irritant and little more stable as compared to hydroquinone. This interferes with the thiol system, which decreases the intracellular glutathione. So this is how it works, and again, it favors pure melanin synthesis. So this is another agent which selectively acts on reducing the hyperactivity of melanocytes. So these three agents Of course, coming to melanogenesis, which of course is definitely there. I put it after hyperactivation because we've discussed melanogenesis because we have, of course, the common agents such as hydroquinone, etc., which work on melanogenesis. Also, of course, things such as azelaic acid, which we haven't mentioned. This is another agent which acts on melanogenesis. So arbutin, deoxyarbutin is, of course, these are two agents, one a derivative of the other, which are finally both derivatives of hydroquinone. This prevents melanosome maturation, and what is very, very important is that it has dose dependent effects and it's got lesser side effects as compared to hydroquinone. So the arbutin, deoxyarbutin, definitely reduce melanogenesis. The second agent we're going to talk about is in this particular category of targeting melanogenesis is oleosin, which is extracted from aloe vera, and that's why we've seen a lot of patients who tell you that they are applying aloe vera. They say that their darkening is a little bit better. It's probably effect of oleosin, which is working on in these particular patients. So of course, it definitely competitively inhibits the conversion of tyrosine to dopa and dopa to dopachrome. We talked about 4-butyl resorcinol, even among the currently available drugs. So I'm not going to talk about this. Coming to flavonoids. Now, flavonoids are, of course, they are benzopyrene derivatives. They are anti-inflammatory, antioxidant. They inhibit tyrosinase. And of course, hesperidine is a particular flavonoid. Now, this protects against ultraviolet radiation induced free radical damage. So, this particular flavonoid has an additional action on protection against free radical damage in addition to it preventing melanogenesis. We come to epigallocatechin and of course ellagic acid. Now these are basically phenolic compounds. These are extracted from green tea. Ellagic acid is also available in strawberries, pomegranates, etc. These are of course comparatively weaker agents. They inhibit melanogenesis, but they also are anti-inflammatory, antioxidants. So therefore, these is also other modalities by which this particular agent works. Gentisic acid, which is from gentian roots, hydroxycoumarins. Now, hydroxycoumarins, of course, again are anti-inflammatory. Cinnamic acid from ginseng, again, it is a tyrosinase inhibitor, and antisense nucleotide, which is the last of the agents I'm going to talk about in this group, which again acts by downregulating the production of enzymes which are involved in melanogenesis. So you have therefore this group of agents which target melanogenesis: arbutin, deoxyarbutin, oleosin. We've talked about rucinol as a current agent, flavonoids, of course, ellagic acid, gentisic acid, the coumarins, the cinnamic acid, and of course, antisense oligonucleotides. So these are some of the agents which target melanogenesis. We talked about the first two groups, one on the hyperactive melanocytes, second, of course, is the genesis of melanin, both related in some ways, but a little different group of drugs which target these two pathogenetic mechanisms. So third, I'm going to talk to you about is inflammation and the generation of a reactive oxygen species. Now, this is a very important mechanism of melasma formation. You see, ultraviolet light we know causes the formation of ROS. This is something which has been known since quite some time. Now, this of course causes oxidant damage to the skin. It interacts with lipids, proteins, DNA, and of course carbohydrates. Now, these reactive oxygen species, of course, activate tyrosinase and of course increase melanin synthesis. And of course, this ultraviolet induced process disrupts the oxidant antioxidant balance. Obviously, the antioxidants reduce. And of course, this generation of these various cytokines following the inflammation caused by these reactive oxygen species, of course, lead to pigmentation. So, this is another very important and, of course, mechanism, and newer drugs are being espoused as targeting this particular aspect of pathogenesis of melasma. One of them is licorice extract. Now, this of course reduces free radical formation. It has other effects as well. Procyanidin, now this is again an antioxidant. Acidified amino acid peels. So these are newer amino acid peels which have antioxidant effect. Orchid extracts, coffee berry, mulberry extract, which also have tyrosinase inhibition, but very importantly are free radical scavengers and antioxidants. And of course, pycnogenol, which are antioxidants and anti-inflammatories. These are some of the drugs which act at this particular level, and that is reactive oxygen species and inflammation. This is another very important target, and that is the targeting of the melanosome transfer from the melanocytes to the keratinocytes, which are actually this is actually sort of engineered, or this is run by the PAR2, which is a very important cog in the wheel as far as this this transfer of these melanosomes from the melanocytes to the keratinocytes are concerned. So here, of course, niacinamide, we all know this. Niacinamide prevents this transfer by inhibiting PAR2. Nicotine and lectin. These are two agents. And of course, the other agent I'm going to talk to you about is soy milk. Now, soy milk has got two important actions. One of them is this, and that is the inhibition of PAR2. But soy milk has got one more effect, and that is related to the next pathogenetic mechanism I'm going to talk to you about, and that is disturbance the skin's barrier function in melasma. So soy milk not only prevents this transfer by acting at R2 and inhibiting it, it also reduces or restores the skin barrier function. So the barrier function of the skin is being found to be a very important aspect of melasma. Now it's been seen that with the generation of melasma because of ultraviolet light, the genes which are involved in lipid metabolism, that is PPR alpha, arginine lipoxygenase, all these enzymes which are involved in lipid metabolism, these enzymes are impaired, and therefore lipid metabolism is impaired, and this leads to an impaired stratum corneum integrity. Now, this is, of course, an important aspect, and this leads to basically a problem with the fact that we are using a lot of topical corticosteroids in melasma, and corticosteroids we know damage the barrier function of the skin, and that's why prolonged use of continuous topical corticosteroids is never a good idea. So therefore, this is an important wake up call for all of us. Again, if you have melasma with an adult atopic, you need to be careful because their barrier function will be even more compromised. And of course, if lasers are used in a patient of melasma. So we know that melasma is associated with a barrier defect. So therefore, the risk of post-inflammatory change is higher in these patients. So this is an important, and therefore it has been seen that soy milk and soy proteins work to improve the barrier dysfunction which happens in melasma in addition to it inhibiting PAR2, which reduces the transfer of melanosomes from the melanocytes to the keratinocytes. So soy milk has these two mechanisms, and this is one particular aspect of melasma I'd like to draw your attention to. So avoid doing too many things in patients of melasma because they already have a disturbed barrier. The next thing I'm going to talk to you about is, of course, the vascular component. Now, what is important here is that ultraviolet-induced, release of plasminogen occurs from the dermal vessels, and this plasminogen activates VEGF, and when VEGF gets activated, this increases melanin synthesis through the VEGF receptors located on the melanocytes. So that is how the ultraviolet radiation is linked to plasminogen, linked to vessels, linked to VGF, and linked. to melanin production. So this is a very important, another important mechanic by which melasma develops. And of course, we cannot leave tranexamic acid here. We know that tranexamic acid acts very importantly on this particular aspect of melasma. It inhibits, of course, this plasminogen plasmin pathway. The plasminogen-plasmin pathway is also important in acting as a bridge between keratinocytes and melanocytes. So this interaction between keratinocytes and melanocytes are uh, are conditioned by plasminogen. So therefore, if you are actually plasminogen and plasmin pathway, so if you are actually acting at this pathway, you are inhibiting this interaction, which reduces melasma. So therefore, tranexamic acid not only acts directly on the vascular pathway, it also works on this by interfering with this keratinocyte melanocyte crosstalk, which happens in melasma. And that is why tranexamic acid works as well as it actually does. So definitely, like we see that it working in even patients where vascular component clinically or dermoscopically is not something which we see, but the drug works, and that's because of this interference of the melanocyte keratinocyte crosstalk of melasma. So of course, as I said, it causes some dermal changes to happen, and of course, this is a very important drug when you're doing procedures because this prevents the post-procedure pigmentation which happens in melasma, and studies have shown it to work, and we see clinically that patients who do not respond to topical respond once you add tranexamic acid to their treatment. Now this has become almost now all my patients except the very, very mild transient melasmas, which are less than a year old melasmas, and also mild. I probably don't use tranexamic acid. Otherwise, all my patients of persistent melasma, which are more than a year old melasma, and all my moderate to severe melasmas receive tranexamic acid and do well. Now, tranexamic acid, of course, the method of using, one needs to understand that it's best to use it for about 4 to 6 months and give it a break. And then one may need to reuse it after a period of time, but it's best to use it for in 4 to 6 month bursts and then give a break of this particular drug. Now, this is what I was talking about, the role of histamines and mast cells. Now, how does this pan out in melasma? Now, this system works by three mechanisms. One, of course, histamine synthesis from by UVR stimulates directly the proliferation of the melanocytes through the H2 receptors. The second method by which this works is by the activation of the mast cell tryptase, which leads to the extracellular matrix degradation and causing basement membrane disruption. Now, basement membrane disruption we know is a very important aspect of melasma pathogenesis, the pendulous melanocytes, etc., etc. And of course, mast cells also produce VGF and which promote vascular proliferation, which is important in melasma pathogenesis. So, therefore, mast cells have actually three mechanisms by which they cause melasma: proliferation of melanocytes, basement membrane disruption, and vascular proliferation. So, therefore, this the targeting of mast cells now and probably going forward with better agents might be a great idea going forward. However, unfortunately, the standard antihistamines do not seem to work on these mast cells of melasma. That's something which we still don't know why they don't seem to be working. Probably these mast cells are different in a way, but tranexamic acid works on these mast cells. Zinc or zinc sulfate, I mentioned about zinc sulfate, topical zinc sulfate, that works on these mast cells. And I mentioned about Q-stimbiag lasers. Now, those also work on the, and that is the low fluence variety, work on these mast cells. So, there is a method currently to target these mast cells, and probably, hopefully, we should get better methods of targeting these cells as well in the future. Now, the next is the estrogen receptor. Now, this is very interesting because, estrogens, we know they upregulate the synthesis of enzymes which are involved in melanin production, all the various enzymes. Now, what is very, very important is drugs, which are estrogen receptor modulators, they are already available. Drugs such as tamoxifen, drug aromatase inhibitors like anastrozole, then letrozole. So all these drugs are available and they have actually been shown to improve melasma. So isn't that interesting? So we have actually drugs even now which we are probably not using, which actually target this mechanism. So it said that this is a publication by Cohen in 2017, where this is a triple therapy in the of the future would probably something really different. It would include hydroquinone, it included all these anti-estrogens systemically, and maybe a VGF inhibitor. Of course, we do have a VGF inhibitor in tranexamic acid even currently available. So something like one of these drugs with tranexamic acid with hydroquinone, or another hydroquinone clone, um, maybe a better agent which inhibit hyperproliferation. We talked about some of those drugs which prevent reduce proliferation of or hyperactivation of melanocytes or reduce melanization. So one of those drugs, along with an anti-estrogen and a VGF inhibitor, of course, drugs such as tranexamic acid or something even better, might be the triple agent therapy of the future. This is another interesting newer hormone target. Now it's been seen that a topical flutamide has actually been used. We know that flutamide is an anti-androgenic agent, and this being seen that this agent also influences alpha MHS and cyclic AMP, and these are of course regulators. So topical flutamide has been found to be almost as effective as focused hydroquinone. So let's see how this thing pans out in the future. Certain drugs with a unique mechanism of action. One of them is curcumin, which is of course your standard haldi. So curcumin has various, mechanism. Which it's a well-established drug in traditional medicine. It's been used in all parts of India, very predominantly in the southern part of India. It's been used in various other systems of medicine. It has got various mechanisms. It inhibits the ultraviolet B-induced production of reactive oxygen species. It inhibits the expression of matrix metaproteinases, and of course it blocks the activation of ultraviolet B induced NAPK as well as NF kappa B as well as activate protein 1. So therefore this is an agent which has multiple mechanisms of action. It repairs the photo damage skin. We know photo damage and dermal elastosis is an important part of melasma. So therefore, this is another mechanism by which this drug is beneficial. It is anti-inflammatory. We know topically and systemically it's anti-inflammatory. It has got free radical scavenging ability. We know it protects against ultraviolet action. So therefore, this is an interesting agent, and if we have probably better drugs which has this particular ingredient, that would be interesting. And of course, it works both topically and systemically. So this is an interesting, it's not a new agent, but a new thought regarding an older agent. Of course, studies have been done which have been found has been found to be almost as effective as hydroquinone, and of course, much much safer than hydroquinone 4%. So the next agent which has got a unique mechanism of action is lignin peroxidase. Now lignin is actually structurally very similar to melanin. So anything which actually is a lignin peroxidase would destroy melanin as well. And this is a drug which works relatively fast. And of course, when we talk about any disease in dermatology today, PRP can never be left far behind. So PRP also seems to work in melasma. Again, I have got no experience on using PRP, but PRP seems to work in melasma, and this basically improves the synthesis of collagen in the dermis. So this is an interesting mechanism. It also is PRP contains in the alpha granules TGF beta one. This TGF beta one is actually delays the extracellular signal regulating kinase activation, which leads to inhibition of melanin synthesis. So TGF beta one, which is there in the alpha granules of platelets, as well as the fact that PRP in general causes synthesis of collagen. These are two mechanisms that might be useful in melasma. So three agents which have got slightly different mechanism. We talked about tryptamine, lignin peroxidase because of its structural similarity to melanin, and of course PRP. Theoretically, yes, it does seem to have a beneficial effect in melasma. So if you see some of these agents, some of these newer agents seem to have a reasonably good evidence. There seem to have been trials done in all some of these newer agents. So therefore, we are progressing in some of these newer drugs as far as melasma management is concerned, which act on the various pathogenic mechanisms I told you. So when you talk about evidence in melasma, Cochrane can't be left behind. Now, the last Cochrane database review on melasma is pretty old, and this basically I mention this because some people might want to know that in as far as the Cochrane database review is concerned, I think there is a review which is in progress at the moment. So triple combination therapy seems to be a more effective therapy. Azelaic acid seems to be working quite well. There is a new agent which they mentioned, of course, which is a proprietary combination, which I'm not going to talk to you about. But hydroquinone seems to be, of course, definitely better than ascorbic acid. And of course, seems that hydroquinone with the use of IPL seems to be better than hydroquinone alone. So therefore, the Cochrane database within 2010 really doesn't add much to our knowledge. But I just wanted to show this for you all to know that this is what the Cochrane says. The triple combination, azelaic acid, and of course hydroquinone. So these are some of the agents. Newer sunscreens. So the newer sunscreens are important. And what is new in these sunscreens? One thing is, of course, visible light blocking. That is very, very important. That's because this visible light causes reactive oxygen species formation, leading to DNA damage. So therefore, visible light protection becomes an important aspect of sunscreening in melasma, especially in darker skins. The second thing is infrared light. So protection against visible light as well as infrared light, because infrared light provokes the activation of the endocrine receptor B and of course the MAPK, which facilitate melanogenesis. So infrared light also stimulates MAPK as well as endocrine receptor B, and therefore protection against visible light as well as infrared light. Visible light protection, of course, you know, iron oxide and tinted sunscreens are available now. So therefore, these newer sunscreens are going to be good. So therefore, definitely these newer agents and of course sunscreens with added antioxidants are also now available. So therefore, these newer developments in sunscreens are a good idea in melasma management. I towards the end, I'm going to talk to you about topical methimazole. Now, just one publication thereafter, nothing really much happened, but this is an agent which again inhibits tyrosinase, and of course, another agent is of course the pidobenzone, the topical pidobenzone 4%. So these are two agents which were published some time back, seems to have gone to the background, but maybe sometime in the future these agents will come into focus because both tyrosinase inhibit melanin. Probably something which those of you youngsters listening to this who might be interested in working on it might think of trying out some of these agents as well. So in my book, to treat melasma, treat them with topicals and of course tranexamic acid. So that is my go-to treatment of melasma. I use peels very, very rarely in melasma. until and unless my tranexamic acid doesn't seem to work alone. I combine it with peels, but never use peels or lasers and lights alone. Lasers and lights, very. I have used the low fluence Q switch in a couple of patients, two, three, four patients, maybe five, six patients. Not a large number in those who do not seem to respond even with chemical peels and tranexamic acid. So I go in this particular manner as far as melasma management is concerned. So therefore, medical treatment till today remains the cornerstone. And if you're using any procedures, please ensure that your medical treatment, either topical, definitely systemic tranexamic acid is on when you're treating so that it prevents the rebound hyperpigmentation which occurs when you treat these patients. So again, this is for some of you. Lots of studies on melasma in the literature. Actually, the reason why there haven't been good Cochrane reviews on melasma is the fact that lots of studies use various outcome measures which are not comparable. So it's always good if you're doing new studies on melasma, use the MASI or the MASI scores. And now we have the objective measures. We have the mexameters, we have the colorimeters, we have the reflectance spectrophotometers, if possible, skin biopsies. Skin biopsies may not need to be done, but definitely some objective measure of measure of the pigment is important because we know skin color is dependent on three factors. It's dependent not only on pigment, it's dependent on the vasculature, it's dependent on collagen as well. So there are various. So therefore, the assessment of skin color is an assessment of all these three factors. So it's good to have an objective measure when you are assessing a particular agent in melasma. Of course, and if you're doing a quality of life study, it's best to have a standard quality of life index like a MELAS-QOL to assess these cases. So this is, of course, those of you who want to study melasma, please use some standard outcome measures so that people who are actually working on trying to get garner evidence are helped by taking your studies and actually using it as part of systematic reviews. So to conclude, so longer duration melasma, the harder they are to treat. And that is why we talk about the transient, or we used to talk about the transient and persistent melasma. You have melasma, and then, of course, the role of light and hormones. And once they go beyond a year, they become much more difficult to treat. So therefore, photo protection in that first 1 year becomes so very important, and treating it because it becomes important in that period because once it becomes longer, it becomes much more difficult to treat. You might require longer duration of use of triple combinations, which are never good, knowing the fact that there is a barrier defect in melasma. So we need to take up medical history because various people have got various predominant etiological mechanism out of the mechanisms I've talked about in a particular patient. Some people it might be more genetic, some people it might be more hormonal, some people it might be more inflammation because of reactive oxygen species. So there could be various mechanisms. In some people it could be more vascular, some people it could be more of dermal damage and dermal elastosis. So a good history and for causes and exacerbating factor is good counseling of these patients regarding the fact that these treatment needs to be may not be lifelong but almost lifelong. Till about the age of 55 or so is what I tell my patients. So of course, topical hydroquinone continues to be the most extensively studied drug, as I've told you. But there are newer approaches which are available, and these newer approaches need to be incorporated into our treatment. Currently, of course, as second line agents or as second line topical agents, but at some point in time, if you get newer drugs working on the same mechanisms, they might become first line, and we might not need to use a topical steroid containing triple combination. Of course, the one thing which I'd like to mention here is the role of microneedling. Microneedling is associated with less post-inflammatory pigmentation. as compared to other methods, and microneedling can be used for drug delivery. In fact, I've started using microneedling as a drug delivery modality in some of my melasma patients. So microneedling as a drug delivery modality could be an interesting solution as we go forward. So I thank you all for a patient listening, and I'd like to acknowledge DocMode and Dr. Sudha of DocMode, who was really helpful in ensuring that we are able to actually get this through to you all. And of course, USV Pharmaceuticals, of course, my talk had nothing to do with their products. They were very cooperative and supportive in sponsoring this particular session. Thank you, ladies and gentlemen.
Okay, doctor, now we can go for the question and answers.
Yeah, I think I'll just stop the screen share. Okay, so we'll go to the Q&A. So hi, sir, I have deep pigmentation on my cheek because sun exposure and friction. Uh, okay, so this is somebody from Hyderabad. Ram, I'm working in marketing. I have dry skin. My age is 26, pigment deep. So, sir, tell me which laser treatment or what treatment is suited of my skin type. Actually, Mr. Ram, I think I'll have to see you and need some more details. So, because you mentioned you got deep pigmentation around my cheek because of sun exposure and friction, but I don't know your skin type. I don't know how long you've been having melasma. What is the extent of melasma? So I'll have to actually see you and then decide. Now, pigment is deep dermis layer. And all melasmas are actually epidermal and dermal. So I really will have to see you to be able to take this call. Dr. Sheetal, I don't know where she's from. So, okay, how do you approach refractory melasma cases? So, my approach to refractory melasma cases is firstly counsel them regarding the requirement of sunscreening even at home. That is very, very important. Sunscreening when they go into the kitchen, infrared protection is important, and I go on to using good physical blocking agents. Especially, a lot of these women are actually working in the kitchen. So then I give them treatment. I tell them that you cannot stop it, and as I said, 8 weeks to 12 weeks of continuous triple combination, then weekend therapy, and during the week I give them a non-steroid containing agent containing any of the newer agents, and I add on tranexamic acid to their regimen. Now, if this doesn't work in a period of 4 to 6 months, which is very, very rare, let me tell you, then I go on to procedures such as chemical peels. But most of these patients, if you tell them to actually practice sun exposure very strictly, they seem to work quite well. In fact, now with COVID happening, with women using masks, actually melasma is getting better. So can adding kojic acid to hydroquinone preparation reduce hydroquinone side effects and be given for a long time? Not no evidence to show that. So it's not that bad. In kojic acid, yes, might increase efficacy a little bit, but adverse effects not really. Long-standing melasma case, what would be your treatment choice? Again, as I told you, I go for standard triple combination, then I go to weekend triple combination with a non-steroid containing agent in the other parts of the week. Then I add on tranexamic acid, strict photo protection, and of course, most of these patients do respond. But actually, we need to tell them that look, you are going to have to treat medicines for a long time. Now, can glycolic acid peels be safe in children? Okay, actually, I don't know what age you're talking about. Beyond the age of 12 years, it's not a problem. In fact, even beyond the age of 6 years, not a problem. But why use chemical peels in children? I've never used chemical peel in children. Dr. Manjiri from Mumbai. Sorry, I forgot to tell the names. So Dr. Sheetal was, Dr. Dhanraj talked about kojic acid to hydroquinone. Dr. Maithili asked about the long-standing melasma. Jigar asked about glycolic acid peel in children. Dr. Manjiri from Mumbai, in what conditions do we directly start with triple combinations? So I start with triple combinations in all patients until and unless there's a patient who's already using topical steroid based combos. That is important. If a patient is already using topical steroid based combos, already has adverse effects, and I do a dermoscopy in all these patients, already has, let's say, telangiectasia, etc., then I don't use a topical steroid based triple combination. Then I straight away hit them with a non-steroidal with tranexamic acid and sunscreens. So probably, all my new cases, all my virgin cases of melasma go for triple combination straight away, until, as I said, if they are on other treatments. Dr. Shriyam from Trichy is asked, clinical efficacy of ascorbic acid. Ascorbic acid doesn't seem to work alone. Ascorbic acid has got various actions on melasma. I told you all about some of them. But ascorbic acid seems to work best when you combine it with certain other agents, or I use ascorbic acid in a week therapy along with weekend. That's what I've done with weekend triple combination with ascorbic acid in the week. That does two things. The collagen damage which is happening because of using a triple combination steroid is partly mitigated by using ascorbic acid. Dr. Giriraj from Thane wants to know which cases can use steroids in melasma. Steroids alone in melasma? Never. I never use steroids alone in melasma. So again, fluocinolone is the highest strength steroid that I use. I don't go beyond fluocinolone. So beyond that, and plain steroids in melasma, no, not really. We don't use it now. And the reason for it, though, of course, has got a, as I said, non-specific inhibition of melanin synthesis, but steroids damage the epidermal barrier, and that is very important, and therefore better to use it for as lesser time as possible. In fact, even the weekend topical steroids, I don't usually go on with this for more than about 6 months, after which I normally treat these patients only with the non-steroidal agents, and probably use the triple combination in between as a short duration to get any new pigment off and continue using the non-steroidal agents. Harish from Nasik wants to know, what is the reason for melasma occurring most commonly during pregnancy, and how do we manage? I think we've discussed this. This happens basically because of hormonal influences, the estrogen and progesterone. So the hormonal influences are what causes the melasma in pregnancy. And how do we manage it in pregnancy? Of course, I treat these patients predominantly with sunscreening agents and sometimes the use of topical vitamin C. I don't use a topical retinoid in pregnancy. I don't use triple combination. So I normally treat them predominantly with sunscreens. I don't use, of course, definitely no oral agents except for maybe some vitamins as antioxidants, but mostly with sunscreens and ascorbic acid is one agent which I use sort of quite regularly. Is it, now you ask the same question, is it advisable to treat PIH by lasers, or can it cause more inflammation? So PIH can be treated with Q-switch Nd:YAG lasers, but I normally combine them with oral tranexamic acid. In fact, I start the tranexamic acid before to prevent PIH caused by the laser. So you can do it provided you do it the right way. Dr. Prashant from Bangalore wants to know, can peels work faster as compared to medication in younger women? I don't think so. Please don't use peels alone. Peels are always your second line management. That means your patients are already on first line treatment. So never use peels alone. Peels, of course, are a good revenue generation, but if you're generating the revenue, please ensure that the patients are on medical treatment also, and preferably, as I said, also on oral tranexamic acid, because glycolic acid is known to cause PIH. In fact, all studies on glycolic, whenever we use it, PIH is a common problem. So Dr. Prashant, okay, I think, okay, so this Dr. Mala Saranathan from Vishakhapatnam wants to know dose and duration of tranexamic acid. So I mentioned this. So my experience, tranexamic acid is actually excellent. It works very, very well. The only issue with tranexamic acid is that when you take it off after 4 to 6 months, you can have recurrence of melasma occurring after some time. That can happen. And when that does happen, sometimes you may need to restart the oral tranexamic acid. So I use it for about 4 to 6 months initially, and thereafter I stop it and I wait. When case I continue them on topicals, in case the melasma I see it recurring, I maybe give it for a short duration, maybe a month or two. The melasma goes down, I take it off, and I keep treating it that particular manner. Dr. Meera from Chennai wants to know, does the treatment differ in elderly, children, and pregnant, or based on gender? So gender, not really. Gender, not really. Yes, of course, we'll not use hormone-based therapies in melasma, which we are in any case currently not doing. But in future, if we start using hormone-based therapy, we're not going to use that in males. But elderly people don't really get melasma, because once their hormonal influence goes away, elderly people don't really get melasma. Children, melasma is not really common. Pregnant women, as I told you, we try to treat pregnant women predominantly with pregnant safe agents, and I very frequently use sunscreens along with topical ascorbic acid in a lot of these patients, and they seem to do well. Dr. Krishna P. from Kolkata talks about tetrahydrocurcumin can be used alone, has to be in combination with other depigmenting agents. Tetrahydrocurcumin actually can be used alone, but I use this after I have used my initial first line triple combination, and then I go in for this agent. Sometimes I use it in first line. In fact, a lot of times when these patients are already been on, topical steroid based triple combination, sometimes even mometasone based triple combinations from GPs, when they have adverse effects, you can see them, with typical telangiectasias, etc., especially if you do a dermoscopy. And then I go in for probably one of these agents, which are which do non-steroid containing as a first line, including tetrahydrocurcumin. Dr. Lashmi wants to know, can we treat refractory melasma with lasers? Yes, you can, as I said, but it's not really very frequently required, very frankly speaking. I have used it in very, very few patients, and I use it as my third line management. My medical treatment, including my systemics, my first line. Then I go in for chemical peels, and as I said, I don't use glycolic acid peels. I use some of the milder peeling agents, or I use salimandelic peel. Salimandelic peel, as I said, because of higher molecular weight of mandelic acid, seems to work better. But if these patients do not respond to any of these, that is probably the time when I use low fluence Q switch Nd:YAG laser. It's the only laser that I use in melasma. But you wouldn't need to use it for very large number of patients. Okay, Dr. Rao from Bangalore wants to know, what is the maximum time period we can prescribe hydroquinone? Okay, now this time period actually varies from individual to individual. So normally in these cases, I keep seeing these patients. I never prescribe hydroquinone alone. It is not an agent which I use alone. It's always a combination as a part of my triple combination. So normally when I prescribe hydroquinone, I never use it for more than about 3 months or so, even as a part of combination therapy. So 2 to 3 months, that is the maximum duration. Now, but if you really want to know, it's best to probably look for adverse effects. And if the patient is starting to develop problems, that is the time you can actually withdraw. There is actually no prescribed maximum period of use of hydroquinone. Previous fears of malignancy, etc., have now roundly been refuted. So malignancy is not really a major problem, but other adverse effects in the form of irritation, and of course exogenous ochronosis is one thing. So if you start developing these small confetti-like depigmented macules, take it off. So Dr. Gopalakrishnan from Chennai wants to know the best topical combination we can prescribe in the young population of your choice. Best topical combination in the young population. So best topical combination, I feel, is the triple combination, definitely. After the triple combination, again, there isn't really one drug which is better than the other. You can use one of the curcuminoids, you can use hydroquinone kojic acid combination, you can use plain kojic acid, you can use one of the newer agents which containing arbutin, you can use nicotinamide. So any of these agents can be used depending on the patient and depending on the severity of melasma. Dr. Amala from Calicut wants to know. Oh, sorry, no. The next question is treatment of choice in other facial pigmentation, periorbital and perioral. I am sorry. This is a talk on melasma, so probably you'll have to get in touch with me personally. Because this is going to be another long discussion. So I'm not going to talk about anything other than melasma today, because this is restricted predominantly to melasma. Dr. Amala wants to know. I will just tell you in very brief. Periorbital pigmentation could be because of one of various factors. It could be because of vascular. It could be because of laxity. It could be because of pigment. So we need to decide. It could be because of a tear trough deformity. So what is the cause? We need to actually decide. Perioral pigmentation, again, what is the cause? So it all depends on what is the cause. So it's actually a subject of another long discussion. So Dr. Amala from Calicut wants to know microneedling can be used with topical treatments. Any side effects? Can we use hydroquinone preparations with microneedling? Actually, you can use hydroquinone with microneedling. You can use any of the other. I don't use topical steroids with microneedling because of only one reason. I'm scared of barrier defect occurring. But I have used microneedling with some of the other modalities of treatment. So it definitely can be used. In fact, sometimes patients can be, you can give the patient a really smaller microneedles, and patient can actually use it at home if the patient has been taught properly only on the melasma involved areas. I have done that as well. So no real side effects. No, if you have taught the patient exactly what is to be done, and if you use the right agent to treat. Again, don't use triple combinations. Don't use a topical retinoid with microneedling. Having difficulty now, Dr. Sundarajan from Hubli wants to know, having difficulty treating recalcitrant, any specific drug we can use in a 40-year-old woman with diabetes? You can use actually all these agents. None of these agents are contraindicated in diabetes. So each and every one of these agents, as I said, in recalcitrant melasma, the thing which really what I've seen is that these patients, their photoprotection, the ingredient they're using in photoprotection, they probably don't have a physical blocker for visible light. They don't have a UVR blocker. They're not photoprotecting when they are in the kitchen. So that is one of the, they only photoprotect when they go out into the sun. But that is not the problem. They need to have photoprotection even if they're in their houses. Even the ambient light in the rooms is a problem. So I think if you actually tell them to use their treatment properly, more or less it works. And of course, tranexamic acid has become a boon these days. Any Mala Saranathan from Vishakhapatnam wants to know any systemic adverse effects you have come across. Systemic adverse effects, I am sure you mean tranexamic acid. Not really, except a bit of GI disturbance, no real major problem. In fact, actually speaking, except probably for one report, there is no report of tranexamic acid in the dosage used in melasma causing a deep vein thrombosis issue. So that is not a real problem. So it's not a problem in when you're treating with just 500 milligrams per day. Komal Makkar from Rohtak has got two questions. How do you manage acne with melasma together? It's a very common problem. We use an acne specific sunscreening agent which are meant for acne. That is, these are lighter sunscreening agents, silicone based sunscreens or gel based sunscreens. Along with, of course, we don't use a triple combination. I use a lot of topical retinoid here which works on both melasma and acne. And we tell them that, look, we're using a topical retinoid. I use vitamin C quite often. I use azelaic acid in these cases. I, in fact, a lot of times alternate glycolic or azelaic acid along with a topical retinoid. But we need to tell patients that this patient is going to take time to improve. In fact, if you saw that lady whom I had shown you, the beginning, she had acne with melasma. So they do respond. Only thing is, don't use a topical steroid based agent. The next stage question you asked is use of tranexamic acid in patients who are already on oral contraceptives. It's not really a problem. It's not a problem. I have used it, so it's not really a major issue in if they are using oral contraceptives. I told you they are using, again, the contraindications to oral contraception, you must know. We have that list of contraindications to oral contraception. If they have those contraindications, you can't use oral contraceptions alone. If they do not have those contraindications to oral contraception, tranexamic acid is no problem. Now, Dr. Ratna Prabha Pisal from Mumbai, she wants to know any experience on intralesional in tranexamic acid in melanoma. No, sorry, I think must be meaning melasma. So intralesional tranexamic acid, I have used it in a few patients. I unfortunately didn't get good results. I didn't get good results with topical as well as intralesional tranexamic acid. In fact, topical I find it a little bit better probably than intralesional, intradermal tranexamic acid. I use a 4 milligram per ml. I didn't really get results. So in fact, I've used it maybe that was a long time back when I used to be an associate professor in Pune. We treated about good, I think 12, 13, 14 patients in one go. Didn't find good results, and then we gave it up actually. So my results with intradermal tranexamic acid is not really very good. So that ends all the questions. With that,
Yes,
can we?
doctor. That's all with the questions now. So, doctor, I'll request you for a short takeaway message for the doctors.
So my short takeaway for all of you would be, oh, there's no light. I just put on my light, I think. So my short takeaway message for all of you would be that when you're treating melasma, be predominantly on medical therapy. That would is what would give you the best results. And of course, trying to find out etiological factors in a particular patient, what is the predominant etiological factor, try and address that. And of course, photo protection at home, photo protection in the kitchen. These are very, very important aspects which a lot of times get ignored. And that is why these patients' melasma become recalcitrant. Remember, the first 1 year is what we call transient melasma. That's the time which where you have the best, opportunity to treat them. After that, melasma becomes a little more difficult to treat. So treat it aggressively early, and you'll get good results. Thank you. I think that's all that I'd have to say.
Yes, doctor.
So should
That's all
I?
with the. So we can go offline now.
Okay. Thank you so much. Thank you, everyone. All of you who've been listening. Thank you.